I'll go ahead and introduce you, and thank you all for your patience. I know that some of our other speakers finished early, so I appreciate you guys being here. And I wanted to introduce Dr. Marr. Dr. Natalia Marr is a distinguished physician and medical researcher. She is currently an associate professor at UC Irvine Child Comprehensive Cancer Center, and she specializes in the treatment of genitourinary malignancies, including prostate, bladder, kidney, testicular, and penile cancers. Throughout her career, Dr. Marr has contributed extensively to medical research. She is a principal investigator or co-investigator on many clinical trials evaluating new therapies in genitourinary cancers. She has authored multiple peer-reviewed publications and presented her research at various national oncology meetings. In addition to her research, Dr. Marr is also committed to educating the next generation of medical professionals. She has been a mentor to many aspiring physicians and has been recognized for her outstanding contributions to medical education. Welcome, Dr. Marr.
Thank you so much, Carmen, for this kind introduction. And I so appreciate the invitation to be here today. So I am a genitourinary medical oncologist, and I thought about what would be relevant and interesting to talk about today. I don't want to bore you with a boring lecture, so I made it into a patient vignette type format. And I wanted to highlight new and exciting research that was recently kind of presented this year at ASCO GU and the Big ASCO, and kind of frame the presentation around 3 interesting studies that were highlighted during these research meetings. Okay, so here we go. So these are my disclosures. So let's dive right in. So the first patient is a 72-year-old man who developed 3 episodes of gross hematuria. He had a CT scan of his abdomen and pelvis that showed asymmetric bladder wall thickening and perivesicular fat stranding, but no suspicious lymphadenopathy or distant metastasis. He was seen by urology and had a cystoscopy that showed a tumor in his bladder involving the UVJ and a second tumor that was at the bladder neck. He then went on to have a TURBT procedure where the tumors were removed, and pathology showed high-grade urothelial carcinoma, invasive into muscularis propria. CT chest to complete the staging was negative for metastasis. He has a decent renal function with a GFR of 75, and his ECOG performance status is 1. So the question is, what is the next step in management? So the choices that we have are proceeding straight with radical cystectomy, giving this man neoadjuvant chemotherapy with dose-dense MVAC, giving him neoadjuvant chemotherapy with cisplatin gemcitabine, giving him neoadjuvant chemotherapy with carboplatin gemcitabine, proceeding with intravesicular BCG treatment, or doing concurrent chemoradiation. So anyone want to volunteer an answer or a guess?
Depends on the situation, plan for the surgery, neoadjuvant cisgen, and then surgery, one option.
Okay, that's a really good choice, really good choice. So let me kind of walk you through this question. Let's dissect it a little bit. So basically, this guy has muscle invasive urothelial bladder cancer that appears to be non-metastatic, but he does appear to have maybe locally advanced disease. So the stem of the question says he has perivesicular fat stranding, which means he likely has T3 disease or stage 3 disease. His tumors are also in a problematic location, which is the UVJ and the bladder neck. So typically patients with tumors in those locations are not candidates for bladder preservation. This question is also saying that he's in fairly decent shape. He has a good performance status, a good renal function. So it sounds like he likely would be a candidate for surgery, which is kind of the first step in the decision tree. So we know surgery is probably going to be in his treatment plan. And also, we don't see any obvious kind of contraindications to cisplatin in this case. So likely he needs some kind of cisplatin-based chemotherapy and surgery in the mix. Chemoradiation is not a good choice because of what we stated. The tumors are not in a great location for radiation. BCG would undertreat him because it's commonly used for non-muscle invasive bladder cancer, and we know he has muscle invasive bladder cancer. And the first four choices seem to be kind of on the menu. So let's go through this a little bit. So management of non-metastatic muscle invasive bladder cancer. So radical cystectomy with urinary diversion is the preferred treatment for muscle invasive bladder cancer if the patient is surgery eligible, which this patient seems to be. Adding platinum-based chemotherapy perioperatively, meaning either in the neoadjuvant or adjuvant setting, improves outcomes following cystectomy. There was a large meta-analysis published in 2005 of 11 neoadjuvant chemotherapy trials that included over 3,000 patients and showed a 5% absolute survival benefit with addition of chemotherapy at 5 years. The reason to consider doing chemotherapy in the neoadjuvant space versus post-operatively is that you have immediate treatment of micrometastatic disease. You have downstaging of surgically unresectable tumors, and you're also selecting out patients with very aggressive disease who may rapidly develop metastasis and would thus undergo an unnecessary cystectomy. So those are the benefits of neoadjuvant chemo. And typically at this point, most patients are considered for neoadjuvant chemotherapy. Now, which regimen to choose is the question. So historically, we have not had any prospective randomized trials comparing the current chemotherapy regimens to each other. They have been historically compared to MVAC, which is a kind of older regimen that is not really used at this point because of toxicity. But the regimens, the modern regimens, were not compared to each other in a prospective fashion. So until recently, we had 2 retrospective reviews comparing neoadjuvant chemotherapy regimens. The first one was a smaller review published in 2018, and it included 319 patients that had either dose-dense MVAC, cisgem, or carbogem. And the endpoint that we look at in this setting is something called pathologic complete response, meaning that you gave neoadjuvant chemotherapy, you went to surgery, and nothing was left behind in terms of tumors. So that's the best case scenario. Another endpoint that we look at in this space is pathologic downstaging, meaning that you had neoadjuvant chemotherapy, you went to surgery, and you downstage the patient from their original clinical stage. So those 2 are the 2 endpoints that we look for in this space. So this first retrospective data set showed improved rates of pathologic complete response and downstaging and OS with dose-dense MVAC compared to other regimens. There was a larger review, again, retrospective review of over 1,000 patients, and this was published in JAMA Oncology in 2018. And here, the complete pathologic response rate with dose-dense MVAC was 41%, roughly, with cisgem 24%, and with carbogem about 9%. So there was a trend towards OS with dose-dense MVAC, but not statistically significant. So this is kind of all we had in this field. So in the community, dose-dense MVAC and cisgem were kind of interchangeably used. Carbogen, maybe not so much, because I think it's fairly clear that carbo should not be used in the neoadjuvant space. So this was an abstract, a featured highlighted study from ASCO 2023 that just happened earlier this month. And this is our first prospective randomized study looking at neoadjuvant chemotherapy regimens. So the study is called VESPER. And this is a randomized phase 3 study between dose-den Semvac times 6 cycles versus cisgem times 4 cycles. This is a European study mainly conducted in France. They randomized 500 patients, and they did allow chemotherapy to be given both in the neoadjuvant space and adjuvant space. But the vast majority of the patients received neoadjuvant chemotherapy. So 437 out of 500 received it in the neoadjuvant space, and then only about 56 received adjuvant chemo. So in the neoadjuvant group, about 60% of patients were able to get through 6 cycles of dose-den Semvac, and 84% were able to get through 4 cycles of cisgem. So again, kind of talking about tolerability, which is always a concern with dose-den Semvac. However, fairly equal numbers of patients were able to go ahead and get the cystectomy, 91% in the dose-den Semvac group and 90% in the cisgem group. So fairly equal numbers of patients proceeded to cystectomy. Overall survival at 5 years, this was 5-year final data from this trial. So overall survival at 5 years with dose-den Semvac was 64%, and with cisgem was 56%, with a hazard ratio of 0.77 and p-value of 0.078. And disease-specific survival at 5 years was 72% with dose-den Semvac versus 59% with cisgem. Here, the hazard ratio was 0.63 and p-value was 0.004. So as you can see, very kind of strong trend towards improved outcomes with dose-den Semvac. They did make a note that the main cause of death was bladder cancer progression in 83% of patients. And then other minor causes of death in the minority of patients were cardiovascular events, toxic death, secondary cancers, and other. So I think this kind of clearly and definitively at this point states that dose-den Semvac is the way to go unless you have a strong reason why you shouldn't do it. Now, looking a little bit ahead, what is the neoadjuvant future? And in my opinion, it's getting away from cisplatin, despite this study. So there have been a couple of trials done with single agent checkpoint inhibitors in the neoadjuvant space. So forgoing chemo and cisplatin entirely. So one study, they were both fairly small, 50 and 69 patients respectively. The first study gave 3 cycles of neoadjuvant pembrolizumab and showed a pathologic complete response rate of 42%. Most responses were in the PD-L1 positive and high TMB patients. And the second study used 2 cycles of neoadjuvant atezolizumab with a pathologic CR rate of 29% and 39% being downstage to non-muscle invasive disease. So I think interesting results, certainly not ready for prime time, but very interesting, kind of thought-provoking results. We also have ongoing trials with combinations of therapies that don't include chemo, like for example, the Volga trial. And this trial combines PD-L1 drug, a CTLA-4 drug, and enfortumab vedotin in a neoadjuvant fashion. And there are other trials kind of looking at other combinations, but I think these are exciting and maybe possibly will replace platinum in the future. So this is kind of where we are right now. Any questions about this part before I move on to the next?
No questions, Dr. Martin.
Okay. So let's change gears and go to our second question. So the second question involves a 56-year-old man who developed 3 episodes of gross hematuria. He had CT abdomen pelvis done that showed a 12-centimeter right renal mass with IVC invasion. Chest CT was negative for pulmonary metastasis. He underwent a right radical nephrectomy and thrombectomy, with pathology showing a PT3B clear cell renal cell carcinoma, WHO grade 3, with no evidence of sarcomatoid or rhabdoid differentiation, very minor tumor necrosis at 5%, positive lymphovascular invasion, and negative margins. And the question is, what is the next step in management? So choices that we have are surveillance for cancer recurrence, adjuvant sunitinib, adjuvant pembro, adjuvant ipi/nivo, adjuvant pembro axi, and adjuvant radiation. Anybody want to take a stab at this one?
Surveillance would be a reasonable choice.
I'm sorry, say it one more time.
Surveillance.
Surveillance is a choice, absolutely. Is that what you're going with?
I would, yeah.
Okay, perfect. Very good. So definitely a choice. So let's kind of dissect this a little bit. So what this question is telling you is that this man at nephrectomy had fairly advanced disease, PT3B. He has clear cell histology. WHO grade was fairly aggressive at 3. So this is the formerly known as Furman grade. And then there are some other features that are listed. So the question is, how worried are you that this man is going to have cancer recurrence in the future and develop metastatic disease? And if you are sufficiently worried, are you worried enough to give him some kind of drug therapy? So in this space, currently, we have 2 FDA approvals to reduce the risk of cancer recurrence post-nephrectomy in patients with high-risk disease. So this is a composite chart of all the trials that have been done with tyrosine kinase inhibitors in this space. So currently, the only drug in the TKI space that is FDA approved is sunitinib, and this approval came out of the STRAC trial, which is the second row in this chart. And you can see that the primary endpoint in most of these trials were disease-free survival. They had variable inclusion criteria in terms of how they defined high risk, whether they accepted only clear cell or did they also accept non-clear cell, and just kind of variable patient characteristics as well. And you can see that sunitinib, out of all of the TKIs that were tried in all of these trials, and the very last trial also looked at everolimus, it was the Evers trial. Sunitinib was the only one that had a hazard ratio that did not cross 1, that the confidence interval did not cross 1. It was the only TKI. So that's why it got the FDA approval. But I think that the community as a whole is not very impressed with this number. There was no overall survival advantage in this trial. And we all know that sunitinib is a fairly toxic drug that you'll be giving for a year. So your patient's going to have a bad year with a very marginal benefit. Because as you can see, the confidence interval for hazard ratio here is very close to 1. It was 0.98, very, very close. So really very, very few people use sunitinib in this space, despite the FDA approval. So really, we have been kind of wondering, are there any other agents, particularly immunotherapy drugs, that we can try in the adjuvant space to reduce the risk of cancer recurrence? So the second FDA approval that we have in this space as of 2021 is with pembrolizumab. And this was a result of this Keynote 564 study. So I'm going to show you the original data from the study first, and then I'll show you an update that was presented at ASCO GU 2023. So Keynote 564 was a randomized double-blind phase 3 study comparing pembrolizumab and placebo in patients at high risk for cancer recurrence post-nephrectomy. It enrolled 994 patients, and the first data cutoff was at 24 months, which is what I'll show you. That was the original data. So this is the study schema, and particularly what I wanted to highlight is how they defined high risk, how this study defined high risk. So patients were basically grouped. So if you look on the left, patients were grouped into 3 different groups based on their degree of risk. The first group was called intermediate high risk of recurrence. And they had 2 sets of patients. One was patients with PT2 disease, WHO grade 4, or sarcomatoid differentiation. The second group was PT3, any WHO grade. So that was your intermediate high risk. So this is probably where our patient from our case would fit into intermediate high risk. The second group was high risk, and these patients had PT4 tumors, any WHO grade, or any stage, any grade, but node positive disease. So those were your high risk patients. And then the third group with the highest risk were the patients who actually developed oligometastatic disease that was completely resected. So for example, they might have had an adrenal met that was removed during the original nephrectomy surgery. They might have had a pulmonary met that was resected, so something like that. So they have shown that they had metastatic disease, but it was treated with surgical resection. And otherwise, these patients needed to have clear cell histology. They did not accept non-clear cell into this trial. They could not have had any systemic therapy for their RCC, and they were fairly fit with a performance status of 0 or 1. And then they got randomized to pembro for 1 year or placebo for 1 year. So this is a really busy slide, so let me walk you through it. So the primary endpoint in this setting was disease-free survival. This is our graph on the left top of the slide. And if you look at the data cutoff, which is 24 months, you see that the curves nicely diverge between placebo and pembro. So disease-free survival for pembro was 77%, and for placebo was 68%. The hazard ratio was 0.68, and the p-value was 0.002. If you look at the right bottom, that's your overall survival. So at 24 months, overall survival was not entirely mature yet, but this is the projected OS. And you can also see a diversion of these 2 lines on the plot. And the hazard ratio was 0.54 in this case. And then if you shift your attention to left bottom, you will see different subgroups of patients. And in particular, I want you to look towards the bottom where it says metastatic staging. And you can see that the M0 patients, although clearly to the left of the line favoring pembrolizumab, the M1 NED patients are way to the left of the midline, right? So what this suggests is that the M1 patients benefited more than the M0 high-risk patients. So just keep that in mind because we'll come back to this. So again, clear benefit with pembro. This is a adverse event table. So if you go in the middle, treatment-related adverse events. So grade 3 to 5 events occurred in about 19% of patients treated with pembro versus 1.2% with placebo. So that's a very significant difference, right? So you're obviously introducing the possibility of AEs if you're treating with pembro. There were no deaths related to treatment in any group. Serious adverse events were seen in 12% of pembro-treated patients, 0.2% of placebo-treated patients, and discontinuation of pembro versus placebo due to serious adverse event was seen in 7.6% in the pembro-treated patients and 0% in the placebo-treated patients. So basically what this is saying is that, you know, yes, you're potentially making a difference in terms of reducing the risk of recurrence, but you are doing this at a trade-off of toxicity potentially. So because of this trial, pembrolizumab got FDA approved. Everyone got very excited. Everyone started using pembrolizumab. However, at ESMO 2022, there were 3 other immunotherapy-based trials that were presented that were completely negative. So one was Emotion 010. This was the second row here. This one was with the atezolizumab versus placebo. There was Checkmate 914, which was Ipi-Nivo versus Nivo placebo versus placebo. And then there was Prosper RCC, which was a perioperative nivolumab versus observation trial. And all of these trials were negative. So hazard ratios all crossed, the confidence interval crossed 1, p-values were not statistically significant, and in fact, Prosper RCC was stopped early for futility. So then, you know, there was a collective pause in the field. What does this mean? Why is the pembro study positive while the 3 other studies were negative with other agents? So I think what this means is we kind of have to be a little bit more selective who we offer adjuvant checkpoint inhibitor treatment to. So how can we find these patients who really truly would benefit from IO? Because again, you're doing this at the expense of potential toxicity. So how can we find these patients? So there are several risk scores or algorithms that have come about to try to find this perfect patient that would benefit from adjuvant treatment. This is one of them. It's called UCLA Integrated Staging System, or UISS. And this algorithm, it looks at type of disease present, metastatic versus localized. The Furman or WHO grade 1 through 4, and the patient's ECOG performance status, 0 or greater than 0. And at the top here, you see the possibilities for localized patients based on T-stage, WHO grade, and ECOG, and these patients are grouped into low, intermediate, and high risk. And the same thing on the bottom with patients who had metastatic disease to nodes or organs that was resected. Again, putting them into low, intermediate, or high risk. And why is this important? It's important because this correlates with a significant drop-off in 5-year disease-specific survival as you progress through these groups. So you can see the numbers on the right. So for example, patients with localized disease who end up in a low risk group, they have a wonderful 5-year disease specific survival of 91%. Patients who had metastatic disease and are in the high risk group, their survival is 0%. So this is a really large range. So this is basically an attempt to find your patient that would benefit the most from adjuvant therapy. There are other prediction tools as well. So this is the one that I use because I think it's a little bit more robust. So this one's called the Ashore Nomogram. So I want to show you this. But this takes into account other pieces of information about your patient besides T-stage, ECOG, and Furman grade. So here, as you can see, it looks at your age at diagnosis of RCC. It looks at tumor size. It looks at histology. Is it clear cell or non-clear cell? It looks at the Furman grade. It looks at presence of necrosis. So if you recall the question in the beginning that I asked you, it mentioned all of those features. So tumor necrosis, did these patients have lymph node involvement, vascular invasion, like the IVC invasion in our question, sarcomatoid features. So this nomogram is much more detailed than your IUSS. So that's the one that I use, but there are others out there too, not just these two. So you can use whichever one you're comfortable with. So kind of going back to our presentation, so this abstract was presented at ASCO GU 2023, and they took the patient population from the original Keynote 564 study with Pembro that led to the approval of Pembro. And they looked at these patients in terms of their UISS risk groups and disease stage, and see if some patients benefited more than others from adjuvant Pembro. So in the Pembro and placebo group, the distribution of these patients was fairly similar. So in the Pembro group, about 73% had UISS intermediate score, about 20% had high score, and then about 6% had M1 NED. And then in placebo groups, very again, similar distribution, 75% had UISS intermediate, 19% high, and 5.8% M1 NED. So these are the disease-free survival curves for all three groups. So the first graph on the left, graph A, is for intermediate patients. The graph on the right top, graph B, is for high-risk patients. And then the graph on the bottom, graph C, is for M1 NED patients. So just visually kind of looking at it, you can see that the most benefit is seen in the M1 patients. And that's kind of what we saw in the beginning when I showed you the original trial data. Remember, I showed you that the M1 patients seem to benefit the most from adjuvant Pembro. And this is true in this case as well. But remember, these are just subgroup analysis. They're not powered on the original study design. So you have to take it with a grain of salt. But all three risk groups benefited from adjuvant Pembro in this particular analysis, although the M1 group benefited the most. This is another endpoint that they looked at, distant metastasis-free survival. And if you look at the very top, you can see kind of similar trend as what I showed you for disease-free survival. So the M1 NED group here, there we go. M1 NED group seemed to have benefited the most. The high-risk group, it did cross the midline, and then the intermediate risk was a little bit to the left of the midline. So then the question is, where does that leave us? What do we do? So in my practice, I don't offer adjuvant therapy to everyone. I do think that there are some patients where that benefit of adjuvant Pembro does not outweigh the risk of toxicity. So again, I try to use some kind of nomogram. Usually I use the Ashore one that I showed you. So I use some kind of nomogram to justify my decision to treat in light of the possible toxicity. Any questions on this piece?
No questions, Dr. Mark.
Okay, we're moving right along. So now we're going to jump a little bit to a different space in the RCC world. So this is our third and final question. A 56-year-old man developed 3 episodes of gross hematuria. CT abdomen pelvis showed a 12-centimeter right renal mass with IVC invasion. CT chest showed multiple pulmonary metastases and enlarged mediastinal lymph nodes. He underwent a lung lesion biopsy with pathology demonstrating clear cell RCC. He was initiated on systemic therapy up front with pembrolizumab and axitinib with iRECIST partial response. He was on this regimen for around 18 months and then started to develop disease progression. I don't know why I wrote she, I apologize. So the question is, what is the next step in management? What do we do in second line is what this question is asking. And choices are cabozantinib, atezolizumab, temsirolimus, ipi/nivo, or everolimus Lenvima. And there's more than one right answer here. Anyone wants to take a shot at this?
Relimus and Vatanid.
Definitely a good choice. And there's really no wrong no wrong answer here, but I'll show you the point that I'm trying to make. So basically, just to summarize this again, this patient presented with de novo metastatic disease. He was treated with IO-TKI up front, had disease progression. What do we do next? So this is briefly I wanted to show you the choices that we have for first-line therapies. So if you look at this row, highlighted in green, these are the combinations that we have to choose from in the first-line untreated space. And above are the clinical trials that led to the FDA approvals for these choices. And if you look at the overall response rates, median PFS, median OS, you can see that there's really no clear winner. There's no preferred regimen. These are all good phase 3 evidence, level 1 clinical trials, strong evidence. So you have choices. And people have very strong opinions about what they want to use, which is fine. But what do we do after the first line treatment fails? And partially that depends on what you use in the first line space. That's one kind of thing to look at on patient factors, costs, things like that. So one question though that has come up is, can we use a checkpoint inhibitor in the second line space after the patient has failed a checkpoint inhibitor in the first line space? Can you reuse a checkpoint inhibitor? So this was a featured trial at ASCO 2023 earlier this month. And this study is called CONTACT-03. So this study attempted to answer the question that I just asked, which is, can we reuse an immune checkpoint inhibitor after failure of an immune checkpoint inhibitor in the first line space, or even in the adjuvant space potentially? So, so this was a randomized phase 3 study that looked at single agent cabozantinib in the second line or third line space versus cabozantinib with atezolizumab. So all of these patients needed to have metastatic renal cell carcinoma, and this trial did accept both clear cell and non-clear cell histologies. Patients needed to progress on a prior immune checkpoint inhibitor, and they allowed 1 to 2 prior lines of therapy as long as a patient received prior immune checkpoint inhibitor. This trial enrolled a total of 522 patients. About 55% in the combination arm received immune checkpoint inhibitor in the first line setting, and 51% received in the cabo group received immune checkpoint inhibitor in the first line setting. So this was designed this way to account for the old standard of care, where patients received single agent treatments. Remember when checkpoint inhibitor was approved in the second line space? So that was to capture those patients as well. And then the data cutoff that was reported was at 15 months. So these patients were followed for 15 months. So this is kind of the distribution of patients on the study. So in the top kind of left, we see, age, sex, race, your typical kind of a distribution. and everything was kind of balanced between the two arms. I do want to go to the histology here and show you that the clear cell was the predominant component in both arms in 78% of patients. The non-clear cell patients comprised a minority of patients on this trial, with roughly about 12% in both groups. And then they had about 10% of patients with sarcomatoid features, which we know respond better to checkpoint inhibitors. Also, I wanted to show you that IMDC risk score was mostly intermediate, with about 2/3 of patients having intermediate score, about 15% having high score, and then about roughly, there was a little bit of a disbalance between combo versus single agent cabo. Single agent cabo, there were more favorable risk patients. And then the table on the bottom shows which prior treatments were received by these patients, and you can see a really large kind of range of different therapies that were given to these patients. So this was a very interesting result that maybe was somewhat unexpected, but the overall response rate between the two groups, the combo versus single agent cabo, was exactly the same. It was 41%. The duration of response was actually higher in the cabo arm. It was at 14.8 months versus the combo group, which is 12.7 months. If you look at the bottom left, this is your progression-free survival, which was the primary endpoint for the study. You can see that the curves are practically on top of each other, overlapping, and the median PFS was 10.6 months with combo and 10.8 months with cabo. And then 12-month PFS was 44% with combo and 48% with cabo, with a hazard ratio of over 1. And then on the bottom, we have our overall survival. And again, you can see that the curves are practically on top of each other, with median OS being 25.7 months with combo, not yet reached with single agent cabo. And then 12 months OS was 79% with combo and 76% with single agent cabo, with stratified HR being 0.94, very close to 1, and p-value being non-statistically significant. So this was a negative trial, which was, I think, a little bit unexpected. So both groups did the same. And you can see that in terms of toxicities, grade 3 to 4 adverse events were 68% with combo, 62% with cabo. Grade 5 all-cause AEs were kind of similar between the two groups, and AEs leading to treatment withdrawal were significantly higher in the combo arm, 16% versus 4% with cabo. So, so what's the takeaway here? So the takeaway here is, based on this trial, we probably should not be using a checkpoint inhibitor in the second line or third line space if someone has already failed a checkpoint inhibitor. But this study does, have a couple of criticisms to it. One being that the checkpoint inhibitor that they used was atezolizumab, which is a PD-L1 drug, which there is kind of some thought that is not really effective in the RCC space, and that PD-1s work better in the RCC space, and also that this study included some non-clear cell patients, which may be skewed results in some ways, and that the cabo arm had more favorable risk patients, which maybe skewed the results, but the results are the way that they are, that both groups did the same. There is another clinical trial ongoing with nivolumab plus tivozanib, which is a very recently approved tyrosine kinase inhibitor, versus single agent tivozanib that is attempting to answer the same question. And in this case, they used a PD-1 drug. So that trial has completed enrollment. We're waiting for data. So that would be really interesting to see. But right now, as of this moment, the way that the field stands, I probably would not use a checkpoint inhibitor routinely after failure of checkpoint inhibitor. And that's all I have. Any questions?
Any questions from the group or online?
So what would be your choice? For this?
So I'm gonna go back to my question. So I think there is no set choice. If you look at the NCCN guidelines, they have suggestions. A lot of the times it depends on the situation. So it depends on the regimen that the patient received frontline. It depends on patient factors like what is the shape that the patient is in? What are the comorbidities that the patient has? Insurance coverage also plays a role, sadly, in this decision. But if I was to take this particular vignette, I would probably use Cabo as a second-line drug. Cabo has really decent kind of single-agent data behind it. You can certainly use TKI after TKI. We have multiple studies showing that TKIs work after failure of a previous TKI. But choosing everolimus Lenvima is not a wrong choice either. And you could have gone with tivozanib as a second-line choice, which I didn't list here. So you shouldn't kind of have a specific choice as the only choice. You have to see what the patient received, what the patient looks like. Can they tolerate a more broad TKI, or do you want to give them a narrower TKI? Can they tolerate mTOR? What's going on, and then kind of make that decision.
What about Ipi/Nivo?
So again, very good point. So that's exactly why I listed it there, is to ask you, would you reuse a checkpoint inhibitor after failure of a checkpoint inhibitor? So anecdotally, we do have some retrospective data looking at Ipi/Nivo, and Ipi/Nivo works in a minority of patients in the second line space after failure of IO. It's about maybe like 10-15% of the time that you will see a response by adding a CTLA-4 agent. So again, it depends on the situation. So we have kind of one trial in this puzzle now that was negative. So am I telling you never to use Ipi/Nivo? No, I'm not. But I'm telling you that we had one negative trial that did not show a benefit to adding an IO to Cabo in pre-treated patients after previous failure of a checkpoint inhibitor. So in selected patients, I have used it, but those are very selected patients.
Yes, Dr. B.
I have a quick question on the case scenario of the adjuvant setting. What's the current thinking about the histology presence of sarcomatoid features, either directly coming out to that keynote study with Pembro, or some thoughts about whether the sarcomatoid histology actually provokes a good immune response? It might be a good thing rather than a bad thing. I heard a professor mention at one of those satellite conferences at ASCO. I guess it's a question to think about, but what's your thoughts on that? Or is there any new information about how bad is sarcomatoid histology in that case?
Really good question. So I went back to the design of the keynote study that we discussed, and as you can see clearly, sarcomatoid is right there when you're looking at your patient and assessing their risk of recurrence post-surgery. Sarcomatoid is right there as a separate group. And then one of the nomograms I showed you, which is the Ashore Nomogram, it's this one, does include sarcomatoid as one of their features that they look for. So historically, sarcomatoid patients had horrible prognosis, very aggressive disease, but that has changed somewhat after checkpoint inhibitors came around. So multiple data sets show that sarcomatoid histology tends to be responsive to treatment with checkpoint inhibitors. And if I see sarcomatoid, that's my ipi-nivo patient. So, so with sarcomatoid, you know, high chance of response to checkpoint inhibitors. So I think that that certainly should be a factor when you're considering whether to use the adjuvant pembro or not. That certainly is a factor that you should think about, because again, these patients tend to respond better to checkpoint inhibitors. And again, feel free to use this nomogram to help you with making that decision.
Ipi-nivo is a metastatic regimen and not data, or is there now a small amount of data in adjuvant that you may have mentioned with ipi-nivo?
We don't have any adjuvant data with ipi-nivo yet. I'm sorry, I misspoke in the metastatic space. If I see sarcomatoid, I tend to give ipi-nivo to those patients. But in the adjuvant space, we don't have data with ipi-nivo at this point that's published. So but what I wanted to highlight is that that is certainly one factor that should be considered when you're making that decision about whether to treat or not. Sorry about that.
Thank you.
Do we have any other questions online or from our club? All right. Seeing no questions, thank you so much, Dr. Moore. Really appreciate your time and expertise.
Thank you so much for inviting me. I hope you have a good rest of the conference.
Thank you. All right. And just at this time, I would like us to just take some time to recognize a friend of the Nebraska Oncology Society and a frequent speaker at our events, Dr. Vogelsang, who passed away last September. He was a globally renowned oncologist whose kind bedside manner and accessibility to patients made him beloved by those in his care, and he will definitely be missed by this society and as well as by those who had the good fortune of working with him. And with that, I want to thank everyone for your participation tonight, for your patience with our speaker mishap, and just want to hope that you guys were able to take something away from today's conference. A reminder that I'll be sending the evaluation link and uploading the presentations to our website as well with the recording. And if you have any questions, please feel free to contact me. And otherwise, enjoy the rest of your weekend.